Good afternoon, everyone. So we had a 37-year-old male patient hailing from Bangalore who worked in machine operations. He presented with complaints of swelling of both lower limbs since the last 7 years. This was his only complaint. So he has had swelling of both lower limbs since the last 7 years. As of right now, there is a mild decrease in the swelling in the morning, but the swelling is present throughout the day. So essentially, it does not disappear completely anytime during the day, and there's marginal diurnal variation. He did say that in the initial 7 years back, the swelling used to be present more in the evening. He has no complaints of pain in the leg, no ulcers, no skin changes that he has noted, no history of chest pain, palpitations, breathlessness, dizziness, or any other cardiac symptoms, no frothy urine, reduced urine output, blood in urine, no abdominal distension, abdominal pain, no fever, no injury, no changes in weight, whether they be decrease weight loss or weight gain. There's no heat or cold intolerance or hair loss, and there's no history of medication use or any other treatment that he has been on, except for occasional use of diuretics as prescribed by the local physician. There's no significant past history or family history. He follows a mixed diet, has normal bladder and bowel movements, has sound sleep with a normal appetite, and smokes around 6 to 7 cigarettes per day, but has currently stopped since the last 6 months. And there's a history of occasional alcohol use, around 3 to 4 units every fortnight or so. On examination, he was moderately built, conscious, oriented, and well-oriented to time, place, and person with a BMI of 29.8, which for an Asian puts him in the obese category. Pulse rate was 92 beats per minute, saturation was 96%, respiratory rate was 14 cycles per minute, and his blood pressure was 140/88. There was no pallor, icterus, cyanosis, or lymphadenopathy, but there was grade 2 clubbing in the hands, and bilateral edema, which was of non-pitting type, and right side more than the left, as you can see in the images. He had an injury that occurred to the right middle finger, so that nail change has been present ever since the injury. His systemic examination was normal and yielded no results.
Savanya?
Summarize the case, please.
Yes, so primarily the patient only had complaints of bilateral edema, which has been there since the last 7 years, and currently it does not show any diurnal variation and is of the non-pitting type. He also has grade 2 clubbing in the hands.
So, chronic pedal edema with clubbing, the rheumatological cause, which I would like to think in terms of hypertrophic osteoarthropathy, and this patient hypothyroidism, but clubbing cannot be explained here, and some skin thickening. Like was there any history of skin thickening?
So there is no actual skin thickening on examination, and he didn't give any such complaints either.
Okay. Non-pitting pedal edema. These are my differentials as of now. So.
Any inputs from the audience?
So at this point, it would seem that the person that he has first seen considered lymphedema, chronic venous insufficiency with secondary lymphedema, a pretibial myxedema, and scleromyxedema as the primary things, and the patient had been worked up before he presented to us. So these are the investigations that were already done when he came. So his CBC, LFT, urea, creat, sodium, potassium, urine routine were all normal. His lipid profile did show a slight increase in the total cholesterol by HDL ratio due to a low HDL value. His 8 AM cortisol levels were done, which was found to be normal. A smear was done for filaria, which was negative, and filarial antigen test was done, which was negative. And his thyroid TFT was done, which was also within normal limits. He had a USG abdomen and pelvis, which showed only a grade 1 fatty liver. Bilateral lower limb Doppler was done, both arterial and venous, which showed subcutaneous edema in bilateral lower limbs, but the Doppler was normal. His 2D echo was done, which was found to be normal with an ejection fraction of 60% and no diastolic dysfunction either. There was a lymphoscintigraphy which was done, which was normal in all of the limbs except in the right lower limb, which showed a slight delayed tracer ascent and a faint visualization of the right inguinal lymph node, and no tracer accumulation. He was treated to some extent with compression, but the findings of the investigations didn't match the severity of his swelling. A chest X-ray was also done, which was found to be normal. So this was the
All of these tests were done before he
presented us. So these were the investigations that he presented to us with. So here we did test for the CBC again, which was more or less normal. ESR was 14, CRP was also within normal, creat was normal, and ANA was done, which was negative. Hepatitis and HIV was also done. I'm sorry, I missed that. HIV was also done, which is negative. Rheumatoid factor was done, which was also found to be negative, and his urine routine was normal. As you will note, his LFT is also normal, as is the albumin, not suggestive of that being the cause. His anti-TPO and anti-TG were within normal, but his TSH receptor antibodies were elevated. 1.75 is the normal cutoff, and his was 4.2. But his TSH, T3 and T4 were normal even when we tested them. So with this, we came to a conclusion that the patient most likely had a TSH receptor antibody associated pretibial mixed edema with acropachy. Acropachy being the subperiosteal bone formation that can occur in some individuals with TSH receptor antibody.
So, but we don't usually do a TRAB. TRAB is done in certain scenarios. Why did you think of doing TRAB here?
Okay, see, the interesting part in this particular case is patient has been completely worked up for every anatomical causes for the mixed edema or mixed edema-like picture. One of the doubt we had was that the lymphangiectasis, that lymphatic abnormality, which is there which should have been on both the sides because edema is on both the sides. It was shown in only on one side. Compressive stocking didn't help. One of the differentials is a pretibial mixed edema. So in the pretibial mixed edema, the cause for pretibial mixed edema is anti-TSH receptor antibodies. So here, though there was a normal TFT, since pretibial mixed edema was a possibility, see, one of the things which was emphasized in the early morning lectures was what is your positive predictive value of an antibody that you are assessing. Here, since it's not just me, even the previous person who evaluated also thought of pretibial mixed edema. What I was little wiser than him was I asked for anti-TSH receptor antibodies, and that made us to figure out that yes, this is a TRAB associated mixed edema. So this is where what I am saying. You need to be very clear about your threshold for asking for the autoantibodies. There is a suspicion. When you have a suspicion, relevant autoantibody need to be asked. The TRAB solved the problem. Yeah, I think.
So pretibial mixed edema is seen in around 0.5 to 4.3% of individuals with Graves' disease. In those individuals who also have orbitopathy, that is Graves' orbitopathy or thyroid eye disease, the value is up to 15% of individuals. But only 2.8% of individuals with Graves who also have pretibial mixed edema are euthyroid. So the majority of them will have hyperthyroidism, and more often than not, pretibial mixed edema is seen 2 years after the diagnosis of Graves. But in this case, the presenting feature was the pretibial mixed edema and the patient was in euthyroid state. It is usually bilateral, but it can but more often is asymmetrical and sometimes can be seen as unilateral lymphedema as well, showing an elephantiasis-like picture as well. It is often associated with higher values of TRAB. Our patient only had a TRAB of 4, but usually the mean value of TRAB in individuals with pretibial mixed edema is around 50 or so. 15 to 50 is the more common range. Treatment of this generally includes corticosteroids, compression therapy, and limb elevation. We did initiate this patient on corticosteroids initially at around 1 mg per kg of body weight, which we have continuously tapered down, and patient is currently only on around 10 mg of steroids since 2 weeks back, and has had a decrease in the swelling that he has noticed. We also initiated him on methotrexate, and it is advisable to either initiate methotrexate, azathioprine, or mycophenolate mofetil. In patients with Graves' orbiopathy, MMF is the drug that is advised as per the UGOGO criteria. We can also use pentoxifilin since it has some anti-fibroblast activity, which is the primary way through which these TRAB antibodies cause this pretibial myxedema. IVIG plasmapheresis have also been used with some success. If the patient had hyperthyroidism, we would have to optimize his thyroid hormone levels. Rituximab and teprotumumab have also been used in the treatment, rituximab being the anti-CD20 to reduce the TRAB antibodies, and teprotumumab is an anti-IGF-1 receptor 1 antibodies against IGF receptor 1, which help prevent the fibroblast proliferation and the kind of production of the glycosaminoglycans, which helps treat the pretibial myxedema. Similar to this case, we will just quickly look at one more case of a 41-year-old male. Yeah, so,
Onset of DB2.
yes.
And that would have been a clinical indication of hyperthyroidism in this case. Less likely with his T3, T4 and TSH being normal. But it's a Graves' disease, right? Yes. No, correct. No, the problem in the autoantibodies are, the autoantibodies do not always. No, that's what. In this particular patient, the thyroid seems to be adequately compensated because though there is anti-TSH receptor, the TSH receptor is not adequately blocked by the antibody as a or stimulated by the antibody, as a consequence of which thyroid is remaining functionally fine. It is only it's only creating other than thyroid dysfunctions, because the same TSH receptor has also been shown in the legs, also shown in the orbital muscles, also has been shown the TSH receptors are present even in the T lymphocytes, TSH receptors are present even in the brain. Their exact function for us we do not know. They are there, but they are in a very low concentration in these areas compared to what is present in the thyroid. If in this particular case, the 92 was on his coming to the hospital. So, 92 is reasonably fine. We have to only depend on whether he has a higher pulse rate in the sleep. So, it could be just an anxiety which would have caused his 92.
Thank you.
Yeah.
He did also have features of metabolic syndrome to some extent with some central obesity, and the blood pressure was also slightly on the higher side.
Yes, sir. Doctor.
Apologies if I'm going to embarrass myself with this question, but mechanic, his occupation was mechanics?
Yes, sir. Yes, sir.
So, a mechanical occupation, chronic history of lymphedema, non-pitting, and a hemoglobin of 70. Can asbestos be a differential diagnosis? The entire pretibial myxedema has been worked up. So, with asbestos exposure from his occupation, hemoglobin a little on the polycythemic side, could have, X-rays would not pick up my interstitial lung disease. So would a PFT and an interstitial or a HRCT thorax would probably be a good differential, sir?
Yeah, as far as his exposure to asbestosis is not there. He was actually a mechanic with
like machine
lathe
operator,
machine.
machine operator
working with
primarily.
lathe machines and etc. So he was not exposed to asbestosis per se from the history. He had no significant breathlessness or anything.
No breathlessness.
Polycythemia, we attributed it to his smoking. He was a chronic smoker except 6 months back.
Yeah.
He is off smoking from past 6 months. And of course, we didn't do PFT or any other tests in him because we thought more towards the pretibial myxedema because it was a non-dependent edema. It's not a pedal edema or a dependent.
Sir, I want to know whether anti-TRAB antibodies has a prognostic value, as in when we treat patients with proptosis.
She's going to come.
Okay.
But there is an association where higher TRAB is associated with higher recurrence and even after treatment, and the values do sometimes reduce with treatment, and patients also, those with lower values are less likely to develop these, though this particular case was unusual in that front. So we have another 41-year-old male who is an accountant hailing from Bangalore, whose primary complaint is double vision since the last 6 months and drooping of the right eyelid since the last 6 months. So he has had, this is a more recent case, so he has had double vision since the last 6 months. There's no variation throughout the day, so it's not that he's having fatigue in the evening or any change along with as the day progresses, and there's no variation with head posture either. There is also a history of drooping of the right eyelid, which was noticed by him. There was some improvement in symptoms since initiating medication, which he has initiated since since 6 weeks before he visited us. There was no eye pain, vision loss, no trauma, no fever, no headache, eye irritation, redness. There were no sensory symptoms, no weakness of limbs, no difficulty swallowing or facial asymmetry or any other cranial nerve involvement. There was some amount of generalized fatigue, no weight loss, and there was some dry skin on asking the question. But otherwise, his only complaint was the diplopia and the drooping of the eyelid. There's no other significant past history. He follows a vegetarian diet with a normal appetite, normal bowel and bladder movements, sound sleep, and no significant family history. He was started on prednisolone 10 mg once a day since the last 6 weeks before visiting us, and pyridostigmine 60 mg once a day before visiting us. So he was moderately built and nourished, conscious, cooperative, well-oriented to time, place, and person, with a pulse rate of 84 beats per minute, respiratory rate of 12 cycles per minute, and a blood pressure of 110 by 70 millimeters of mercury. This particular photo was not taken when the patient visited us, but was taken 2 months prior to his visit by the patient himself. By the time he did visit us, the ptosis that you notice in the right eye was not as significant. The difference between the two eyes was not so severe, and his diplopia had also improved. Cranial nerve examination was normal, and the patient was able to move the eyeball in all the directions. But you can notice some changes both in the right eye and in the left eye in the image, and his systemic examination was found to be normal. This was the evaluation that was done outside. So his CBC was found to be normal, ESR was 12, CRP was 4.1, which is normal but marginally elevated. Creatinine was 1.04, rheumatoid factor was 12.62, which is negative. His LFT was normal, AST, LT being 23 and 30 respectively, and the urine routine was found to be normal. Acetylcholine receptor antibodies were done, which was 0.03, which was negative as per the reference range, and ANA was also done, which was negative, and anti-MuSK antibodies were negative. A repetitive nerve stimulation test was also performed on the bilateral facial, median, and ulnar nerves, and was found to be normal. And an MRI brain was done, which was also found to be normal. But he did have improvement on starting steroids and pyridostigmine.
Thyroid status was not evaluated.
Not outside. These are the reports that were already in them. So again here, we tested for the anti-TPO, anti-TG, and the TSH receptor antibody. Anti-TPO and anti-TG were normal, but the TSH receptor antibody was elevated. But his TFT was normal. CPK was also done to rule out ocular myositis, just in case, but was found to be normal. We also did a HRCT test just to check for a thymus or any other involvement, and that was also found to be normal with no. So this was most likely a case of Graves' ophthalmopathy or thyroid eye disease, which is how it's referred to now. And there is still a possibility of an overlap myasthenia gravis, but one thing that we did, one option was to test for other antibodies that were missed out. Instead, what we did do was we increased the dose of the steroid that the patient was on and asked him to stop the pyridostigmine for a few days. It has been 3 weeks since he was stopped on pyridostigmine, and he has had no worsening of the symptoms, and his vision is also maintained. So the chance of the overlap myasthenia is less likely. Although both thyroid eye disease and myasthenia gravis can coexist, since both have similar HLA differences between myasthenia and Graves. So it is frequently associated with hyperthyroidism, but around 10% of patients can be euthyroid or even have underfunctioning thyroid. Usually ptosis in thyroid eye disease can be either because of the lid edema or aponeurotic ptosis, a contralateral lid retraction which makes this eye appear like there is ptosis, so a pseudoptosis in a sense, and overlap myasthenia, which in this individual, both with the repeated nerve stimulation and this thing, it has been excluded. So again, the treatment would be smoking cessation, which this patient was not smoking anyway, but had he been. To maintain euthyroid status, again, if there was any issues. Eye drops, and to some extent, selenium supplementation has been found to help in minor in a more minor diseases. Steroids, again, mycophenolate or azathioprine, mycophenolate being the preferred drug as per the UGOGO criteria. Rituximab and teprotumumab, if required. Teprotumumab is what is advised by the American Society, and orbital radiotherapy, decompression or surgical correction if the patient is in inactive disease. So, thank you. Any